Here we go. Okay. All right. Well, welcome everyone. Thank you so much for being here tonight. I'm very excited to welcome you to our August NF2 related Schwann meetup. I'm very excited about our topic tonight, and I hope that everyone here is as well. We are welcoming our speaker, Dr. Leslie Kim, just in a short while here. But first I want to just go over some housekeeping. So first I'll say that, my name is Kate and I work with CTF. And if you have not seen me on these meetings before, then it's lovely to see you. My primary role with the, CTF is managing most of our patient-facing programs. So things that touch and interact with the NF community is generally my area. So I'm happy to be here with you tonight. We do have closed captions available by a live captioner here tonight. So if you click on the CC button at the bottom of your screen, you should get those activated. If you're having any trouble with that, please drop a note in the chat so we can be sure to take care of it. Remember to keep your microphone muted so that we can hear our presenter. And we are recording this event. So if you do not want your image recorded tonight, just keep your camera off so that that's not a problem. And I want to encourage everyone as we're getting started to introduce yourselves in the chat. I'd love to hear where you're from, where you're calling in from tonight, and your connection to NF. That would be a lot of fun. It's a nice way to get to know each other a little bit. And we will have a Q&A at the end where we invite folks to unmute and ask questions after our presenter is done speaking. But you're also welcome to drop questions into the chat as we're going through the presentation in case you're worried you'll forget or you're not comfortable speaking. That's completely fine. I'll make sure that those questions get to our speaker as well tonight. Okay, so having said all of that, I'm very excited to welcome Dr. Leslie Kim as our speaker tonight. So Dr. Kim is a double board certified otolaryngologist and a facial plastic surgeon, and she specializes exclusively in the aesthetic and reconstructive surgery of the face. So aesthetic facial surgeries can include rhinoplasty, facelift, otoplasty, and reconstructive facial surgeries often include nasal obstruction, reanimation after facial paralysis, and other things of that nature. Dr. Kim has been working with the NF2-related schwannomatosis community for a long time. There we go. Has been working with this community for a long time, and she was highly recommended to me as our speaker for this topic by Oliver Adunka. And for those who don't know, Dr. Adunka is the chair of the NF2-related schwannomatosis accelerators and has been since 2021. And we're very grateful for his time and attention to this program. And we're very happy to introduce you and welcome Dr. Kim. So I will hand things over to her. Looks great.
Okay, wonderful. Well, thank you so much for inviting me to speak to you all today. I've prepared about 45 slides or about 30 minutes of talk, but please do not hesitate to ask questions. And I do want to make sure that this is informative for all of you. So I'm going to be talking today about contemporary facial reanimation. Definitely need to start by talking about the facial nerve. So I'll give you some background. So the facial nerve has about 10,000 neurons. So that's what carries the nerve signals, and 7,000 of which innervate the muscles of facial expression. So as you can see here, it starts in the brainstem, the back of the head, and it travels through the temporal bone, the bone behind the ear. It exits around the ear structures and then comes out through the mastoid bone right here, and then exits through the stylomastoid foramen here to then send off. Let's see if I can advance here. Lots of branches across the face. And so we generally see branches that move our forehead and our eye up here, branches that move in the middle of our face. We call them our zygomatic and our buccal branches, as well as marginal mandibular branches that come down into the chin, and then cervical branches that come in the neck. And it's really important to know that there's a lot of overlap in the middle of the face. So this is just a pictorial diagram. In real life, the branching pattern can really vary from person to person. But what's important to know is there's a lot of overlap in the middle of the face and less so in like the forehead and the lower lip. And one of the things that's important from a facial reanimation standpoint is that when patients recover from paralysis, they're going to recover from the center of their face outward because of that overlap. There's a lot more nerves here than, for instance, your forehead or the lower lip. So those tend to be the last to come back. So the ultimate function of the facial nerve is to provide innervation or electricity, as I like to tell patients in clinic to 43 muscles in the face that are involved in facial animation and expression. So what are causes of facial paralysis? The most common cause of paralysis in the face is actually Bell's palsy, which is paralysis of unknown etiology. And then very shortly after that are your acoustic neuromas or vestibular schwannomas, as well as various other types of cancers, surgical injuries, and trauma, etc. When I see a patient with facial paralysis in the clinic, really the questions I'm going to be asking are, what is the cause? When did it start? And what's the duration of paralysis? It's very important for me to understand more about the age, the medical history, and function of the patient. And then in the exam, we need to do a full cranial nerve examination. And why that's relevant, I'll talk about more later. And then I like to really assess the face in zones, looking at the upper face, the middle face, and the lower face. And then really understanding what's the presentation of paralysis. Is it complete paralysis or incomplete paralysis? Has there been some recovery? Has the recovery gone well or poorly? And then taking photos and videos to really document the appearance at rest, as well as a full range of movements. And then we have, as physicians, facial paralysis grading skills, which makes it easier for us to communicate the severity of the paralysis. So when we look at a patient with paralysis, there's complete paralysis, which are your classic patients who look like they've had a stroke, where everything is droopy. So the eyebrow is droopy. The eye can open fine, but it can't close. Opening is a different nerve. So closing the eye becomes a problem. We tend to lose the fold of the face, and then the mouth tends to droop, and everything just kind of sags. There's a very different presentation when you have incomplete paralysis, specifically incomplete paralysis after recovery from a facial nerve injury. And I'll spend a bit of time towards the end of the talk talking about these patients. But when you have incomplete paralysis, it's a very different picture. So looking on this side of the face, incomplete patients may often look normal at rest, but when they try to move their face, they're unable to move it, but they look a little bit more different. Whereas droopy patients tend to have a big eye because they can't close it. Incomplete patients tend to have a tight eye. They tend to have a crease that's pulled up. They tend to have a lot of dimpling and tightness kind of throughout the face. And again, I'll explain more of that later. So when it comes to looking at somebody who tends to have more flaccid paralysis or the droopy type of paralysis, eye protection is the most important. And the reason this is important is because when you have an eye that doesn't close, the cornea or the outer covering of the eye is unprotected. And when it's unprotected, holes and ulcers can form, which can lead to blindness. And so this is actually the most important thing when it comes to somebody who has new onset paralysis, is that we really want to encourage a lot of lubrication, eye drops, ointments, moisture chambers, taping, etc., just to protect the eye. And then oftentimes we'll put eyelid weights to help patients close their eyes. So you can either use platinum or gold. I tend to prefer platinum. And then you can do lower lid tuck-up surgeries to really help that lower lid to really sit up higher so that the tears can disperse around the eyes better and obviously look better as well. So while eye protection is the most important, what I often hear from patients is really, I want my smile back. And so that tends to be one of the most common goals for patients who present with facial paralysis. So I'm going to spend the great majority of this talk really talking about the options today for dynamic smile reanimation. And so what does that mean? Dynamic reanimation means trying to get that smile back, right? And so obviously when somebody is droopy, you can do suspension procedures really to tuck things up and kind of hold them in place, but that won't help somebody's face move. And really, getting that smile back tends to be one of the most common goals and probably one of the most difficult things to achieve. So here are some really important principles that I tell patients, and I think is important for also practitioners to know, that when we talk about facial paralysis, It really has everything to do with the facial muscles rather than the facial nerve. So what does this mean? The clock starts ticking for the facial muscles from the day of onset of facial paralysis. So when the muscles of the face don't get that energy from the brain through the facial nerve, really whether you can reverse that paralysis has everything to do with facial muscles. And why this is the case is that when muscles don't get innervation or energy from that brain, they develop atrophy and fibrosis, resulting in irreversible paralysis. So, in lay people's terms, basically, when muscles don't get energy from their brain, over time they become non-functional, and over time that non-functionality becomes a permanent thing. And so these muscles, when they become fully fibrosed and atrophied and they can't turn back on again, you can't actually send in more energy to those muscles. They're sort of goners, meaning that the only way to restore movement is to replace the muscle altogether. Whereas when muscles have been sort of newly paralyzed, they are called reversibly paralyzed, and they still have the systems to be able to turn back on again. And so in these cases, we try to reinnervate the muscles to really try to bring back tone and symmetry and movement to the face. And so when it comes down to like what procedures you can offer for somebody with facial paralysis, it's really determined by whether the paralysis is reversible. And a surrogate marker for understanding reversibility is how long somebody has been paralyzed. And so we generally say that reversible paralysis is somebody who's been paralyzed for less than about a year and a half to 2 years. And in these patients, really the goal for us as facial nerve surgeons is to reinnervate. We want to try to bring more energy or different energy into the facial muscles so that we can turn them back on again. And so in the NF2 and vestibular schwannoma population, it's really going to be nerve transfers that we talk about. And then in the irreversible category, these are patients who have been paralyzed for too long, so over 2 years, over 3 years, or these patients are born without facial nerves and muscles. And in these patients, we have to replace the muscles. And so I'll talk a little bit more about this, but we call them muscle transfer procedures instead of nerve transfer procedures, because again, we're trying to replace the muscle. And we could do that by surgeries called temporalis tendon transfer or free gracilis muscle transfer. So when we talk about nerve transfers, essentially this is like a bypass. So when we talk about this, it basically means like your facial nerve you had, for instance, a vestibular schwannoma or a vestibular schwannoma surgery, and it knocked out your facial nerve. And so you woke up, for instance, from a surgery and you're paralyzed. And you've been paralyzed for a while and the nerve does not seem to be turning back on. So what can you do in that situation? You can do a nerve transfer. Again, it's not been over 2 years, that muscles are still awake. We can try to turn them back on again. And so the way I explain this is it's kind of like a bypass surgery. We're trying to bypass the facial nerve that won't wake back up and borrow from other places. And so what are our options here? You can borrow from the other side of the face. So this is sometimes not an option in patients, for instance, with NF2 where both facial nerves are affected. But if the other one is not effective, you can try to borrow from the other side. You can borrow from the tongue. So the tongue is called the hypoglossal nerve and it runs in the neck. And so that's an option. You can borrow some from the tongue. You can borrow nerves from a chewing muscle. So the masseter muscle sits right here in the face, and you can borrow the nerve out of that muscle to try to regain facial function. And then there's some other nerves, but those are the most common ones. So here is an example of a patient who underwent nerve transfer, who had not a vestibular schwannoma, but a similar brain tumor. And so this patient underwent a masseter nerve transfer. And so what we did in this case was we took the nerve that goes to that masseter muscle, which is the chewing muscle, and I bypassed it into the facial muscles in order to be able to regain smile again. So this is a patient, again, who had not been paralyzed for too long. It had been about a year. And so we went in and did the masseter nerve transfer, and this is her 1-year outcome. And so when you do a surgery like this, basically what happens is that she has to clench her teeth in order to smile, because when she clenches, the nerve signal is no longer going fully to the chewing muscle. It's now being rerouted into the facial muscles in order to regain smile function. This is an example of another patient with a vestibular schwannoma history. She had actually two surgeries who underwent combined nerve transfer. So in this case, I did both the masseter nerve transfer as well as the hypoglossal nerve transfer. Again, the hypoglossal nerve transfer uses the tongue, and this was done, and this is an example of 10 months after surgery. And so the reason might be, well, how would you decide when to do what? And the short answer is the masseter nerve transfer, or the chewing nerve, can give you a really great smile movement, but you have to chew or clench to turn on that smile. Whereas the tongue nerve, or the hypoglossal nerve, is on all the time. You have two tongue nerves, one on each side of the neck, and they send energy to the tongue constantly. And so you can borrow some function or some nerve from one of the sides and transfer it into the face. And this allows you to have constant nerve energy into the face. So the hypoglossal nerve transfer is much better for increasing symmetry and tone being facial muscle energy all the time. And so it gives you a better symmetrical face, as well as the masseter nerve will give you that smile. And this is another example of somebody who didn't have a vestibular schwannoma, but underwent not only the masseter nerve transfer as well as nerve repairs. This person had a parotid cancer, but also underwent a suspension to give more definition and symmetry to the face. So oftentimes we'll combine different types of surgeries to really get the best outcome. So then let's talk about the situation when somebody is irreversibly paralyzed. So this can sometimes happen where I'll see a patient who had a vestibular schwannoma excised many, many, many years ago, and they had facial function that never recovered. And so when this happens, as I said earlier, you can't, when it's been over 2, 3, 4 years, you can't turn that muscle back on again. And so you have to replace it with other muscles. And so we call those muscle transfers. And the most common is temporalis tendon transfer and a free gracilis transfer. To put it simply, what happens in a temporalis tendon transfer is that we're taking the temple muscle, which is yet another chewing muscle, and we're detaching it from the jawbone and connecting it to the corner of the mouth. And therefore, when you clench or bite the back of your teeth, you can also generate a little bit of a smile. In a free muscle transfer, you're actually doing a tissue transplant where thigh muscle from the inside area of the thigh is actually taken out along with its blood supply and transplanted into the face and connected to nerves, the same nerves actually I talked about before, so that when this muscle basically is in the face, you can try to get it to turn on so that it will act as the new smile muscle in order to regain smile function. And so this is a little video of like what happens in facial reanimation surgery, is that we can connect that temple muscle to the corner of the mouth. And in surgery, you can kind of see when I stimulate it, it can create a bit of a smile. And then this is an example of a free gracilis muscle transfer, again, where that muscle from the inner thigh was taken out. And this is an NF2 patient, and it was transplanted into the corner of the mouth in this face. And then over a 6-month period of time, it was connected to two nerves, one from the other side of the face, as well as the chewing muscle. And this allowed her to be able to regain her smile function again. And so here she is smiling naturally, as well as smiling with a little bit of clench to be able to get her that smile back. So I do want to present this thing because this happens all the time, where a patient with vestibular schwannoma will have surgery and they'll wake up with complete facial paralysis, but they're told by the surgeon the facial nerve was intact. It wasn't cut during surgery. So as a facial nerve surgeon, this is a really tough scenario that I have to talk with patients about, like, because the options are, do we wait? And traditionally we say you should wait at least a year. But the issue is that as you're waiting, as I said earlier, those muscles start to lose their function and their ability to be reinnervated. And so if you keep waiting, you risk potentially the success of a later surgery. But we don't want to do surgery too quickly because you could risk potentially a nerve that's going to recover on its own and therefore perform unnecessary surgery. So this is actually a very tricky situation. And the other thing I've noticed with patients with vestibular schwannomas is that after a big surgery, they have a lot of imbalance and they feel weak and they're not really ready for another surgery so early. So this becomes a lot of discussion with patients to figure out what the best timing is. And I share this article that came out of Hopkins over 10 years ago that was really monumental in our field, that essentially, this is a very busy slide, but the summary of this is that when vestibular schwannoma patients don't experience any recovery after their surgery if they wake up with complete facial paralysis and they experience no recovery by about 6 or 7 months, your prognosis for a good recovery, meaning good symmetry and some movement, is low. And so I tell this study to patients to know that, if your trajectory is such that you're not getting a lot of improvement by that 6-month mark, as difficult as it feels and seems, it is a good time to have a conversation about surgery at that point. But I put this in here, we can't predict everything. And so I spent a lot of time talking about how facial muscles, after about a year and a half or two, will develop irreversible paralysis. We can't turn them back on again. But this is a patient who came to see me 2.5 years after her onset of paralysis on her left side. Because she actually had an ear cholesteatoma. So it's a different issue, but still causes paralysis. And this is a young patient. And so we talked about whether we should do a muscle transfer versus a nerve transfer. And we went with nerve transfers in her case. We did the masseter nerve transfer as well as a hypoglossal nerve transfer of the tongue. And even though we did this 2.5 years after the onset of paralysis, so beyond that 2-year mark I just talked about, she actually got a really nice outcome in both her smile as well as her tone. And so I say this because not everything is tried and true. We have to do things based on how our discussions go with our patients. This patient was really young and healthy, and when you're younger, your nerves tend to regenerate better. And so we decided to go for it and see what happened. And so a lot of the times, these decisions are not just black and white. There is a lot of gray area that requires a lot of discussion with the patient and facial nerve surgeon working together. So I'm going to end this talk talking about post-paralysis facial synkinesis. So 15 to 50% of patients develop post-paralysis facial synkinesis. So what is synkinesis? So synkinesis is defined as the abnormal muscle movement in one area of the face when you try to move a different area of the face. So what does this mean? So in this patient, as she's trying to smile, so I'm telling her to smile, and when she does, her forehead goes up when it's not supposed to. Her right eye narrows when it's not supposed to. So the eye is a circle muscle. And so when it's tight, it squints. Her smile becomes somewhat frozen because there's a lot of muscles trying to fight each other at the corner of the mouth. Her chin dimples when it's not supposed to, and then her neck tightens when it's not supposed to. So I'll explain what all this is, but let's talk about why synkinesis happens. So the classic theory is that when you have a facial nerve injury, for example, from tumor or from tumor surgery, what can happen is that when the nerves regenerate, they don't regenerate normally. They actually, like as you can see here, get crisscrossed in pattern. And so the layperson analogy that I give in clinic is this. When you imagine the facial nerve is like an electrical cable to an old school stereo system where every muscle in the face has a dial. So when you have the onset of facial paralysis, that electrical wire was pulled out of the wall. And then when it was plugged back in, for whatever reason, the electrical wiring started sprouting lots of different wires so that the wire that went to your eye now is sprouted and connected to the wire that goes to your nose, your mouth, the chin, the neck. And so this crisscrossing effect happens. And so what happens to the dials or the muscles? So when you're droopy, all the muscles are turned off. When the electrical cable goes back in, the muscles start coming back to normal. So they start turning back again. But then when synkinesis starts happening, so the nerves get all crisscrossed, the dials all start getting overshot. And so it's a totally different scenario where the nerves are now putting too much energy into the face. And so the muscles are oftentimes not working because they're fighting each other. So when the eye turns on, it's like they're all turning on at the same time and everything is fighting each other. And so this can cause symptoms of tightness, spasms, and asymmetry, and things feel like they don't move, not because they're frozen, it's because they're acting up. They're like Charlie horsing and they're fighting each other. And so going back to this initial diagram that I showed, droopiness is obvious, but on this side, it's not so obvious. It's a little trickier, but this person who has non-flaccid or not droopy paralysis, but synkinetic paralysis, everything is tighter. So the eye is squinty, the mouth is pulled up, the chin is dimpling because it's tight, the neck tightens. So it's a totally different picture, and the treatment options are totally different. And so the biggest information is here. So again, this is somebody who's droopy, and this is somebody with synkinesis who's being pulled down. So it's a totally different scenario. And what's important is that in a person with synkinesis, we don't want to do those surgeries I just talked all about. We don't want to plug more power in. We don't want to do a bypass because more power in somebody who's jumbled up is not a good thing. And so when you're talking about post-paralysis facial synkinesis, the treatment options are totally different. It's going to be therapy, neurotoxin, or more commonly known as Botox, and surgery. So let's talk about what these are. So therapy is called facial neuromuscular retraining therapy. And so what this means is that I just spent time talking about how the muscles are really fighting each other. And so you have to engage in therapy to learn how to re-engage the muscles in a more effective way. And so a lot of the components are first teaching patients to really understand how the muscles are working and how they're impaired. And then using sometimes biofeedback, so using mirrors or EMGs or different things to figure out what's going on with the face. Then really understanding how sometimes gentler movements are more effective in trying to improve symmetry. And so this is somebody who got a better smile just from engaging in therapy. And the kind of layperson analogy is it's like a Chinese finger trap, I think those are called. It's like the tighter you try to pull, the more you can't get your fingers out of that trap. And it's the same thing with synkinesis. I just kind of told you all the dials are overturned, they're overshot, they're working too hard, they're fighting each other. And so with therapy, you're learning how to turn down the dials a bit and so that you can move your face more effectively. Another important part of therapy is massaging and really mobilizing muscles by, palpation and mobile and movement to really try to get them to move better as well. Because as I said earlier, they're like Charlie horsing. So therapy can be done by a number of different disciplines. They could be speech therapists, occupational therapists, or physical therapists. But I do really recommend trying to find somebody locally who specializes in this, because everybody in all of those three therapy fields will say they do facial paralysis therapy. But I think the person who does facial neuromuscular retraining therapy has really gone and had specialized training for this. So if you're in Central Ohio, I have two therapists who are at Ohio State who have gotten specialized training for this, but anybody outside in Central Ohio, I do not believe that they have done this special training, so I can't refer patients to them. So here is a patient who had post-paralysis synkinesis, and this is a Bell's palsy patient. But this is how you can see she had a lot of synkinesis. And this is just a diagram of how these are the 8 pictures we like to take in clinic. And so you can see when she tries to raise her eyebrows, her neck is really getting tight. The corner of the mouth looks like it's pulling downward, whereas the normal side is looking more, straight. When she closes her eye, you can really see that muscle kind of tightening up. And when she tries to smile, you can see that eye really squints and the corner of the mouth is really pulled down. The neck is really tight. So like all these muscles are really fighting each other. And so what is Botox? So Botox is a muscle relaxer that's injected right into the muscles to try to relax them. So going back to my stereo analogy, therapy can try to get the stereo to dial down completely in all areas. Botox, you can just reduce some of the dials to try to make the muscles move better again. So essentially, I can inject this to temporarily relax or paralyze some of the muscles that seem to be working poorly to try to get other muscles to work better. And so here's an example. At the corner of the mouth, when she goes to smile, or when a synkinetic patient goes to smile, on the normal side, the smile muscles turn on. On the synkinetic side, the smile muscles turn on, as well as the muscles that frown, as well as the muscles that pull this way, as well as the muscles that pull down in the neck. So everything turns on at the same time. And so you can Botox or temporarily paralyze the red arrow areas to really try to get somebody to smile more normally. This patient also got some Botox around the eye to relax the eye and open that eye up again. And so this is just a pictorial diagram of how I inject patients. Basically, I have them do different face poses to figure out what's being tight and what's activating, and basically injecting various muscles. And so this is a before and after of somebody who did Botox as well as therapy. So at rest, looks pretty good at rest, but both times, tight eye closure, you can see that neck looks much better. She looks more relaxed. And then you get a lot of the improvements with the smile, as well as the lip pucker. Eyes much more open. There's a lot more control, and she's not exaggerating her movements like she did before. And then there are two types of surgeries that you could do. There's selective myectomy and selective neurectomy. So I'll end by talking about these surgeries. So myectomy, so as when Botox is injected, as I said, it's a muscle relaxer. In certain cases, you can go in and cut some of those muscles that are working in overdrive. And specifically, you can cut the muscle that pulls down to frown and some of the muscle of the inside of the mouth. And so this is a quick video of it. And let's see. It's a little graphic, but basically I showed just the beginning. The muscle that's called the DAO pulls down on the corner of the mouth. And this muscle, when it pulls down on the corner of the mouth, prevents the smile muscle from moving. And so therefore we can go in, and I'm not going to show the entirety of that graphic video, but essentially shows that you can go in from the inside of the mouth to cut that muscle to try to improve the smile function. And so here is a before and an after of a patient who underwent that. And so, you can see this is a normal side and this is the paralyzed side. The smile was kind of more downturned and not as upturned, and it becomes a lot more symmetric after this type of surgery. This is something that could potentially even be done in the office, although I find it personally to be more comfortable to do it in the operating room. And then selective neurectomy, basically what this surgery means is that, again, the dials are overshot. You can go in and actually cut some of those haywired electrical cables or facial nerve branches. And so in surgery, you can go in and find all the facial nerve branches, use an electrical stimulator to figure out what they're doing, and then go in and cut a bunch of the branches that you think are doing that are jumbling up the face. So cut a bunch of the nerves that you think are sending energy to the wrong parts of the face turning on when you're trying to smile, for instance. And so here's an example of somebody who underwent selective neurectomy. And we think today, and this is an evolving topic, but we think today that selective neurectomy may give the greatest potential for smile improvement in synkinetic patients. However, the downside is that if you cut too many wires, you might actually get a little drooping. And so this is a patient who had a selective neurectomy done elsewhere, not with me. And 5 years afterwards, starting to see a little drooping of the corner of the mouth. She's still happy she did the surgery because it did give her a little bit more improvement in smile. But I don't know that we yet know what the long-term outcomes of this type of surgery is. So to conclude, what are some pearls? So to recap, eye protection is the #1 priority for patients, but smile restoration is the most challenging. Timing is everything, as I said, after prolonged denervation or prolonged paralysis over about 2 years, those muscles become irreversibly atrophied. And so we want to dynamically reanimate a face when muscles are still viable or they're still alive and still can get more energy put in and work. And so, really in the NF2 population, your nerve transfers are going to be the mainstay, where you're using a different nerve to bypass that facial nerve that's no longer working. The choice of what nerve depends on the goals, and as I kind of mentioned, combining nerves may be more beneficial than just using one. And so out of the three main options, as I said, masseter nerve or the chewing nerve is really good for the excursion of the smile. The hypoglossal nerve, which is the tongue nerve, is really good for that tone, as I talked about, because it constantly sends energy into the tongue, but now you can reroute that into the face. And then the cross-face nerve graft, which I didn't talk as much about, that's the other side, the other face. This is going to give you the most spontaneity, or what I call emotional smile, because the two sides, if you connect them together, can work better to create that emotional smile. And then smile restoration is even more challenging, never perfect, when those native facial muscles are no longer viable. So after that, about 2 years or 3 years of paralysis, you no longer can turn the muscles back on. You need to replace them. And so muscle replacement procedures are that free gracilis transfer, temporalis tendon transfer, or static suspension. And then, as I mentioned, 15 to 50% of patients develop that post-paralysis synkinesis, which is permanent. And while none of the treatment options are curative, they can significantly improve quality of life, particularly when done in combination. So therapy, non-surgical, which is Botox, and then surgical, which is selective neurectomy and myectomy. So that's all I have in terms of the education portion of the talk. I'd be happy to take any questions.
Thank you so much, Dr. Kim. We actually have a few questions in the chat, so I think I'll start with that. But if others that are here have a question they want to ask, if you could use the raise your hand function. It's also fine to just unmute and ask, but sometimes that's helpful for me to know who to call on. So we'll start with Barbara Franklin, who I know very well. Hi, Barbara. Asked some really nice questions. Her first question was, have you ever used the sural nerve, and what were the results of that? And then she also asked, so I'll give you both and kind of let you take them. Have you ever worked with someone with NF2 who had already had a previous facial surgery?
Yeah, so the sural nerve is the cross-face nerve graft. So the sural nerve is a nerve that comes from your leg muscle or lower leg, and it basically gives sensation to the pinky toe on the side of the foot. And so basically when you're looking at, let's see here. Where did my options go? Here we go. So when you're looking at the nerve options, the cross-face nerve graft is the sural nerve. So you can take this nerve out from the leg. You connect it to the normal side of the face, and it generally goes underneath the lip, and therefore it's sending energy from the normal side of the face across into the paralyzed side of the face. And so it is a great option, as I kind of mentioned, to give you that emotional smile, because it's the only option where when you try to smile, the energy is going to go from the normal side smiling to the opposite side and give you that coordinated smile. Whereas masseter nerve, as I said, will give you a nice smile, but you got to clench to activate it. So it's not necessarily emotional, natural. If you catch somebody in a belly laugh with the masseter nerve transfer, you're not going to get a true smile. And so it works really beautifully. The only downside is the sural nerve coming across the face is about 20-25 centimeters, and nerves grow about 1 millimeter a day. So we're talking about 250 days for that to really kick in. And so in somebody who's had like a vestibular schwannoma, it's not a great go-to procedure unless you're catching them really early. So I just did very recently a post-vestibular schwannoma patient. I did a combined masseter nerve, hypoglossal nerve, and a cross-face nerve graft. So that's like an 8-hour surgery. And I did this because unfortunately her tumor was so big, the facial nerve had to get sacrificed. It had to get cut. In that situation, we know that nerve isn't coming back. We have to bypass it. And so we went in very quickly, several months afterwards, after she felt better from having her vestibular schwannoma surgery, and went in and plugged all of those nerves in. And she's doing great so far. It's a little too early to see any results. So this is a good time to kind of talk about that. A masseter nerve transfer takes about 3 to 6 months to start working. Hypoglossal nerve transfer takes about 9 to 12 months to start working. And that cross-face nerve graft takes the longest, about a year to start working, because it's traveling the most distance. So yeah, hopefully we'll see. I've definitely seen great results from other patients who've had cross-face nerve grafts. They just can't be applied to every scenario. What was the second question again?
Yeah, no, I realized I should ask them one at a time. The second question was, have you ever worked with someone who has NF2, had had a previous facial surgery? I assume, Barbara, that you mean like a previous sort of restoration of movement.
Yes.
Okay.
Yes. I think that I have, and it's tricky, right? So I can tell you actually a patient in mind where I went in and I did the masseter nerve transfer and a hypoglossal nerve transfer, because she had a vestibular schwannoma surgery on one side that after about 9 months or so, a year, did not recover. So we went in and we did the combined two nerves, and then like a year or so later, she got tone back, she got some smile function back. So I knew her muscles were alive, but she wanted me to go in and try to see if I can get her more of an emotional smile. So we actually went in like a year or so later and did that sural nerve cross-face nerve graft. And so she was able to get a little something more out of that, a little more emotional, a little more spontaneous, kind of connected smile. So that is an example of somebody, as long as those muscles are alive and your initial surgeries turn them on, you could potentially supercharge them or bring new or more nerves into it. So the options are there. They're just more complicated and complex the more surgeries you have.
No, that's great. Thank you. And then, okay, so Christopher had to sign off, and this may be a question that is, whether or not you can answer it, but he was talking about whether there are possibilities outside of the face for this type of intervention. So for example, he has an ankle drop, the foot drop, causes lots of injury. He's doing some PT, and he's wondering, outside of the face, is there a future for reanimation surgeries in other scenarios?
That's a really good question. So I really just do facial surgery, so facial and neck surgery. So I don't know, but I do know that there is a plastic surgeon here, Dr. Amy Moore, who does upper extremity nerve transfers. So I'm not sure about the lower extremity. I think so, but I know that this is nerve transfers are definitely done elsewhere in the body.
Yeah, thank you so much. And then let's see, my last question from chat is from Barbara again. And she said, have you ever removed a weight and replaced it with a lighter weight? I don't know, Barbara, if you want to expand on that question, but maybe Dr. Kim, you know what she's asking.
Yeah, I sure do. So let's go back to that weight. Let's see if I can find that picture. Okay, so how do weights work? Basically, they work by gravity. So you insert it, it looks just like this underneath the eyelid skin, so that when you try to go to close the eye, the weight kind of helps it close, right? So it's just a gravity dependent, essentially a static suspension. So you can size somebody's weight. So the heavier the weight, the more you can close your eye, but the more droopy you look, right? And so there's a fine balance between picking one that helps somebody close their eye and blink better without picking one that's too heavy that will make them look droopy or impair their vision. And so we have these things called sizers. So if you're coming in and we're considering you for an eyelid weight, we could tape different sizes to figure out what the best one would be to put underneath the skin, because we don't want it to be visible. I prefer platinum just because compared to gold, you can get a thinner weight in for the same weight because it's a more dense metal. So I have exchanged weights in patients where you pick the right size, you put it in, and then they recover some function, and then that weight starts to get droopy, right? Because now it's too heavy for them. And so in those patients, the safest thing is to wait as long as possible to make sure that eye is really protected. But at some point, it might be that the eye is no longer as bothersome. They still can't close it as well, but it just feels too heavy. Then you can go in and downsize the weight. So The hardest thing in that situation is it's a little bit of a guessing game because if you take one weight out, you can't really size it at the same time. So you're going to have swelling. And so generally speaking, you kind of size it to it goes in 0.2 grams. So you can size it to the next lowest one. But yeah, it certainly can be done. And there are certain patients where I've taken the weight out and they can't fully close their eye, but they just feel and look better. And so they feel like it's fine to live without one, even if they can't fully close it, because they're really diligent about using the eye drops and ointment. And then the other thing I like to bring up as it's on this slide is bandaged contact lenses. So not every eye doctor offers this, but the patients I know who use it just love it. So this is a contact lens that goes on the eyeball to essentially act like a moisture chamber. So it's a little bit bigger than a normal contact lens, but it's put in the same way. And my patients love this, especially when they don't have a weight or they take their way out, because it gives you that extra layer of protection without having something actually in the eyelid itself. So I do want to mention that in case that's something that interests somebody and affects them.
Is that the pros lens?
Yes.
Okay, because my son does have that.
Mm-hmm.
And he has platinum. He's got a chain platinum
Yes.
that bends, a little
Yes.
more flexibly to his eye. But I was wondering if you could actually like take, and I use the word literally, but links out of that existing one. Would that be possible?
Yeah, good question. So I use platinum chain weights as well. And no, you can't take the links out because sometimes there's only two links and there's not like an easy way to cut it. So the best thing to do is just to remove it and put in a lower weight. So yeah, that's the best option for those.
Well, I'm a big proponent. I will back you on the pros lens. Saved his
Mhm.
cornea, which had gotten scratched by being when he wasn't blinking. So
Yeah.
definitely push that.
Yep.
Yeah, thank you, Barbara. I appreciate that. That's really
Sure.
helpful. We did have another question from Susan, and she asked about how, please talk about your sense of how the outcome of a surgery for a patient with synkinesis might be affected by the patient's ongoing chemotherapy to address the vestibular schwannoma.
So hard to know, right? I mean, these are going to be situations that I don't think are really written about, meaning I don't think there's scientific studies that have a group of people with that situation. So I think really those decisions are going to be so unique to the individual, right? And kind of seeing what is the current functionality. I can tell you, like I don't know that there's literature on vestibular schwannoma patients who've undergone chemo or radiation, but I can tell you the most common like group of patients that get radiation with paralysis are going to be your parotid cancers. So salivary gland cancers can often involve the facial nerve because the facial nerve exits through the salivary gland. And those patients, if it's affecting the nerve and causing paralysis, you're automatically going to get radiation because it's an aggressive tumor. And there is at least one study that I know of that's shown that radiated patients don't have worse outcomes when it comes to facial reanimation. So that is encouraging to know that even if you're getting treatments like chemo or proton beam or radiation, that the facial nerve may not necessarily be affected, although theoretically we think it probably does slow down recovery. So I would say very case by case, it's going to really depend on what the patient is looking like, how they're presenting, and really the timing considerations, as I mentioned throughout the talk, is really going to play a role in figuring out what the best timing is in somebody who's still still receiving ongoing treatment.
Yeah. Thank you so much. Yeah, I think that your answer really highlights what this community is all too familiar with, which is that when you are living with a rare disease, there is limited data out there. And so the more that this community comes together and is talking and involved with research, the better it will be for everyone. So I appreciate that. That was my last question from the chat, but we do have some time. But I wanted to just make sure if there's anybody who wanted to unmute and ask a question of Dr. Kim, I want to give you that opportunity. Okay. All right. So we're going to use our last few minutes, actually. I'm excited to welcome Liana Scaglione here. Liana is just a fabulous advocate for this community. I don't know if you follow her on Instagram, but you should be. It's lots of fun. But she recently had an experience that she's offered to share a little bit with everyone. So I'm going to hand things over to you for a few minutes.
Hi. So my name's Leanna, and I actually just had my facial reanimation surgery last week. We did the mesenteric nerve and the hypoglossal nerve for the graft, and then she also put the platinum weight in my eyelid as well, my surgeon, and instantly so much better on the blinking. That's all I can say. 1,000 times so much better. Still healing on the side of my face and the neck. I am very swollen still. But I am very excited. I had my right vestibular removed in January, and I woke up with the droopy facial paralysis. And this is now like the 8-month mark, and we realized all I was getting back was just kind of like very barely able to scrunch my eyebrow a little bit. And so I just wanted that extra push, and I didn't want to risk the muscles atrophying, like you were saying in your presentation. And I am very excited to see the results and, like you said, get my smile back. Literally was the words that I said to my doctors. I want my smile back. So when you started your presentation with that, I was like, yep, that is what we say. So I'm very excited to see what's going on. And obviously, I will be talking about it all throughout my page on social media. As Kate said, you guys can follow me if you'd like at Leanna_running NF2, where you'll see the progress.
Yeah, I definitely encourage you to find her on there. It's a lot of fun, and you do a great job, Leanna, of just talking about your own journey and what you're experiencing. And I appreciate you speaking. It's short, it's brief, but I like the idea that, hearing from you as someone who's recently chosen to do this, and as you began, Dr. Kim, talking about how there's sort of this window of time where we are trying to decide if we're going to intervene. And I've been following on Leanna's story, and I was like, this is exactly what she's been experiencing. So it was just a really nice thing to kind of bring together. So a big thank you to both of you for being here tonight. Dr. Kim, we really appreciate your presentation. I want to let everybody know that if you have questions that you didn't get asked or that you think of later, you can always reach out to us. Sarah has dropped some things in our chat about the NF2 inbox that you can email. You can also reach out to me directly, and I'm happy to answer questions at any time. So the next meetup will be in November, so be looking for information about registering and topics for that. If you ever have ideas for topics or a speaker you think we'd all love to hear from, please don't hesitate to let us know. We're happy to take recommendations. If when you registered for tonight, you indicated interest in becoming a part of the NF2-SWN Accelerator program or hearing from us, signing up for our newsletter, you should be hearing from me. And if that doesn't happen, or if you don't currently get our newsletter, please let us know right away so that we can make that correction to ensure that you're kept in the loop of everything we're doing. And then, like I said, our next meetup should be November 14th, and we'll have more information about that coming out as we get a little closer to that date. So thank you everyone for being here tonight. A big thank you to Dr. Kim and to Leanna for sharing and for presenting. And I hope everybody has a really wonderful evening. Thank you so much.
Thanks, everyone.
Thank you.
Bye, all.